And if you have trouble with sustained or selective attention, that is way too much stimuli. When you're feeding your person with dysphagia, if it's somebody at home, I might recommend like just purchasing like a bunch of little like small bowls, and you put each item into a bowl and give them each item one at a time. We prescribe prophylactic swallowing exercises. So the reason why we do this is we get these patients started with these exercises, and then you have greater physiological reserve as the dementia progresses.
So where does this research come in?
Welcome to the Dysphagia Research Bites podcast, which is a podcast designed to make dysphagia research more clinically digestible for speechies, especially those working in home and community-based settings. My name's Chantelle, I'm a speech pathologist, and I started this podcast because dysphagia care doesn't just happen in hospitals. It happens around kitchen tables, in aged care facilities, and in everyday life. Community dysphagia work is complex, it's nuanced, and it's often underrepresented in conversations about swallowing. So, if you're looking for clinical tips and thoughtful, evidence-informed conversations that actually translate to practice, you're in the right place. This is part 2 of my conversation with Jackie, so you might want to head back to part 1 if you haven't listened to it yet, where Jackie talks about how she developed an interest in dementia. We talk about some biases we tend to hold as speechies working with clients with dementia, and we talk about the role of cognition and the environment. Do you assess smell and vision as well as part of your assessment? If so, do you do that formally or is it informally? Do you just ask about that? What's your approach?
Yeah, that's a good question. So I will say that smell, I don't really do a lot of assessment of smell because, especially like depending on where you're seeing that patient, that can be kind of hard. And I think like here in the United States for, the types of food we typically have stocked are like graham crackers, applesauce, stuff that
Similar
is
here.
not super smelly. Yeah.
Yeah.
But you can assess vision, and I think you should assess vision. And one way that you can assess vision is by creating high contrast table settings. And so as dementia progresses, the visual field becomes smaller and smaller, and the distance from which a person can see makes a big difference. So one thing that if you ever go to like a dementia training course, they'll tell you that it's important to sit at eye level with the patient, not standing, so that they could see you well, and then also for dignity. And then you can create a high contrast place setting by usually they say, so you want the table setting to be in sharp contrast to the plate and the silverware. So think about like if you have a black remote control and if you have a black couch, if you put that remote control on the couch, it's going to be really hard to find it, right?
Yep.
If you have a white couch and a black remote control, that's a very high contrast. It's going to be much easier to find that remote control. So the same thing with our table setting. So what you can do is you could either go and like just buy, you'll see a lot of times red is the color that is recommended to create high contrast for people with dementia. So you can get like a red like placemat, or you could even just get like a pack of construction paper that's red, and just place like a fork and knife on top of it and see if the patient if it's easier for the patient to find that. So that can give you some good information as well, because sometimes patients have trouble with um, the like actual like physical fine motor skills part of feeding, that they're having trouble bringing the fork to the mouth. And that might be something that you consult with OT with to get some built up tools. Or you might look at like handheld type finger foods. But it also could be vision, that the person just is not able to see what's in front of them. And so creating that high contrast setup can make a big difference. Another thing you can do that's kind of visual but more attention is looking at, like, if you're working in a facility, even like an inpatient rehab, like A lot of times facilities will give like these patients like 400 different things on their tray, and then they've got silverware and straws. And if they're on a modified diet, the dietitians are going to have like supplements. And if you have trouble with sustained or selective attention, that is way too much stimuli.
Sensory
So
overload.
even, yeah, exactly. So even recommending like when you're feeding your person with dysphagia, if if it's somebody at home, I might recommend like just purchasing like a bunch of little like small bowls, and you put each item
Mm.
into a bowl and give them each item one at a time
Oh, yeah.
instead of like a plate with a whole bunch of different types of food. I've even had like some facilities have allowed me to write orders that each food item is delivered in like an individual bowl. Or I've had like in memory care where they would just have a stack of little bowls. And so our patients that required feeding assistance, the care partners would just put the food into the bowl and give it to them one at a time. And that can kind of help with that sustained and selective attention on the tray as well.
Great tip. Now, I want to ask a bit about enteral feeding. Do you think that it's generally well known that enteral feeding doesn't prevent aspiration or aspiration pneumonia in people with dementia?
No, absolutely not.
And do you think this is just limited to species, or do you think it's sort of, it's generally among, health, medical, it's just not well known in general?
Yeah, I think it's a combination of both.
Mm-hmm.
Um, I think that a lot of speech pathologists aren't really sure, and then um, other healthcare providers as well sometimes, and then families also. And then even like I've noticed too that a lot of times other health professionals are not good at explaining the nuance of why a feeding tube is not going to help their loved one with dementia. And I think a lot of SLPs shy away and say that like, well, that's not part of our scope of practice. And that is a hill that I'll die on. If we
Mm-hmm.
are the experts in swallowing when an infant is born and we could work in the NICU,
Mm-hmm.
we're experts in swallowing throughout the rest of someone's life. Why does our expertise all of a sudden disappear into thin air because someone is dying? We are
Mm.
still the experts in swallowing, and we should know about death and what happens as the swallow mechanism breaks down at the end of death. And I think that it's a much deeper conversation because a lot of times what is not communicated to these patients, when you think about what this article talks about is how the trigeminal nerve is breaking down, right? So
Mm-hmm.
the trigeminal nerve plays a role in olfaction, it plays a role in your taste. The optic nerve with your eyes is also breaking down. So think about
Mm-hmm.
how, like, when you see a commercial and you see like they're like advertising like this meal, like your mouth starts watering, like your stomach
Mm-hmm.
starts growling, you realize you haven't had anything to eat. A person with dementia is not going to have that same response. That's why we're adding in like what can we do to like add more sense to make the food more appealing because they can't see it very well.
Yeah.
Um, all of this breaks down at the end of life. Taste starts to go. So food is not enjoyable. Your
Mm-hmm.
digestive system starts to break down. So your body is not wanting food like it did before.
Mm-hmm.
And this is such an important conversation for us to have with family members because so many times doctors just say, well, feeding tubes are not going to help a person with dementia. Like, you can still aspirate on the food, but they don't explain that, like, your family member is not starving. They are not perceiving a meal like how you and I, healthy individuals, are. And these family members have guilt and think that like they have murdered their family member because they starved to death because they chose not to give them a feeding tube. So it's like a really important conversation. And it also, like I always like to say too, like our care extends beyond the life of our patients with dementia. That like even I mentioned earlier that like my mom passed away, and
Mm-hmm.
there's still things that like I blame myself for that our family members are also going to do with their patients with dementia. And so I think that like with having these conversations and really helping our family members to understand what's happening with their loved one with dementia, they
Mm-hmm.
can let go of some of that like guilt and blame, and just understand that like this is a natural change and progression of this disease process, and that like, there's nothing that you did wrong that
Mm-hmm.
caused your family member to pass away. So I do think that like this conversation is really undervalued, and we shy away from it too much because
Mm-hmm.
it's, allegedly not our scope of practice, but it is. And I could say like definitively that like doctors are not having these conversations like they
Mm-hmm.
should. And don't be afraid of that, because it feels intimidating, but
Mm-hmm.
it is a really meaningful conversation that you could be having with your family members. So.
Yeah, I think that's a really good point you bring up. I know that early on in my career, I definitely didn't understand what was happening to the body when someone was dying in terms
Hmm.
of, I remember I had a patient who was in a nursing home and they stopped eating. The family had decided they weren't going to go with, enteral feeding. And I just remember thinking, oh, this poor patient is starving to death. What we perceive is happening is not the same as, what is actually happening. And I think that I don't know how common that knowledge is among speech pathologists. So I think that's
Hmm.
really important that you've explained that.
Hmm.
Yeah.
Yeah, for sure.
Um, do you think there are circumstances where enteral feeding is appropriate for someone with advanced dementia?
This is probably a controversial take, but I think
Mm-hmm.
when the family pushes for it,
Mm-hmm.
I think when we have done our jobs correctly and we have
Mm-hmm.
provided education, I think at the end of the day, we have to remember that like our recommendations are just that. They're
Yep.
recommendations. They're not
Mm-hmm.
law. Like we don't get to like force people to make a decision. And there are often times where, people might choose to do something that we know is not necessarily going to help, but
Yep.
if that's what they choose to do, then that's within their rights. And I think that even can extend more, broadly to just swallowing in general and how we make like recommendations for food. When you think about it, like people can leave the hospital with life threatening injuries if they want
Yep.
to. We cannot force them to stay. People
Mm-hmm.
choose every day not to undergo cancer treatment. So
Mm-hmm.
I think that even when we, like I mentioned, it's tricky because I know a lot of times family members are not getting the education that they deserve, but
Mm-hmm.
sometimes there could be like cultural factors or religious factors where even if you have gotten the best education, there's just not going to be a lot of acceptance, and that they are wanting a feeding tube, and that sometimes we just have to do what the family is pushing for. So.
Yep. And like what you said before, when you shared your own experience of your mother passing, you said that you were thinking or you felt some guilt about there could have maybe been more that you did. And I just wonder, if we're sort of pushing families to make a decision, say, not to go ahead with a peg tube, their
Hmm.
family member passes away, are they going to also have some sort of guilt or think, should I push harder as a family member? Maybe that wasn't the right decision. Should I have done things differently?
I totally agree. Yeah. And I
Yeah.
think I actually talked about this at a conference once, and one of my attendees brought up a really good point that when we do have these hard conversations, we should provide some sort of alternative of what the family can do that's helpful. So,
Yep.
like a feeding tube might not extend the life of your family member, but you can sit and sing to them. You can sit and
Mm,
talk to them and play
mm-hmm.
music. You can do hand underhand feeding. So
Mm-hmm.
I don't know if you're familiar with the difference between hand overhand and hand underhand. In the dementia world, there's a lot of conversations about hand underhand feeding because it's a more natural type of support. So when you think about it, if someone's like got their hand over your hand, it feels like someone's grabbing you, right? And
Yep.
forcing you to do. Whereas if you lay position your hand under your patient's hand and you're kind of helping to hold on to the cup or the spoon, it feels and also looks to them as if their own hand is moving. So, teaching family members about how to do that carefully and how to read for signs that, like, your family member is comfortable or not uncomfortable. So, then there is still that power that there is something that I can do. And I'm not just sitting here helplessly feeling like I can't do anything to support my family member.
Yeah, great. Yep. Those were all the things that popped up for me, the questions I had for you. Jackie, was there
Mhm.
anything else that you wanted to share with our fellow species that you haven't already gone
Yeah.
over?
So earlier we talked about oral apraxia
Ah,
and
yes.
yeah, how that can be like a super intimidating and also kind of a scary moment where you go to give that patient like a bite of food and all of a sudden like they're not swallowing and you're like, "Oh, what do I do?" Um so I like to conceptualize this similarly to how I conceptualize verbal apraxia. So, when we think about our patients who have had a stroke and who now have verbal apraxia, acquired verbal apraxia, we
Mhm.
think about like integral stimulation, like that cueing heart hierarchy, right? Where we start
Yep.
with models and then we kind of ease away with how much support we give. And you'll see how, like, a patient tries to say one word, they cannot do it by themselves. But then when you're saying it with them, they can say it very easily. So, we take that same framework kind of and apply it to our patients with dementia. So,
Hmm.
what I always like to start with, if I'm noticing that like a patient is bolus holding, or if I suspect that they have some oral apraxia happening, is I will get two sets of utensils and two cups, and if I can, two plates, but
Hmm.
oftentimes that's a little bit harder. Um, and then I'll also get for the patients have their items, I have my items.
Hmm.
And then I'll also get like another cup and spoon and I'll fill the cup with ice. And I'll stick my spoon into there. And if they have something that can be chilled to like applesauce or a drink, I'll also stick that into the ice as well. And so I
Hmm.
start with the modeling. So a lot of times patients cannot motor plan to be able to feed themselves. But if you sit and you grab a cup and you hold it up to your mouth, they will imitate you. So that's
Mm-hmm.
one thing that you can try to do. And that's
Right.
actually safer when we think about how, like, one of the risk factors for aspiration pneumonia is reliance or dependence on another person
Yes.
to feed them. So if you
Hmm.
can get a person to eat an imitation, I've even taught care partners to like sit and eat with your patient with dysphagia, or do the same
Hmm.
thing I do, have the cup, um, and then if they have like a soup or something that can be poured into the cup, or even
Hmm.
like sometimes like certain purees, like it sounds weird, but like giving yourself like a little sip of mashed potatoes is much easier to coordinate than like trying to get the spoon in your mouth. So that's one thing
Mm.
you could try.
And that's more
Um,
representative of, for most people, how we would normally eat, isn't it? For most people, we're
mhm,
not sitting there and eating
mhm.
by ourselves. Yeah.
Right, yep, and even I've done this in modifieds too. So, like, I'll do
Ah,
my entire modified in imitation with the patient,
yep.
because you wanna see, when they're feeding themselves, like, are they aspirating versus when I give you, like, this teeny tiny controlled little sip. Um,
Yes.
and then another thing I'll do is just alternating the temperature. I see a lot of success with that. So
Yep.
Tristani in the article, she talks about like applying pressure and alternating temperature. So I take that extra cup that I have with a spoon in it. The spoon is nice and cold. So even if it's a
Mm,
hot bolus, when they feel that cold spoon on their tongue, a lot of times that will trigger the oral phase of the swallow to begin because you have
mm,
better awareness of the bolus in your mouth. And
yep.
then you can even do like a small bite of a warm bolus and then another bite of a cold bolus. I would not advise a warm bite and a cold sip because they're probably going to have a lot of trouble coordinating those mixed consistencies. So that's
Yep.
something to think about. Um, But those are some things that I do in terms of like helping to with those patients with oral apraxia. And then you also, when you give them the bite with the spoon, pressing down hard on the
Yep.
tongue, sometimes that also helps to initiate the oral phase of the swallow or oral transit, really.
Yep.
And then the last thing that I wanted to briefly touch on as well is the concept of proactive swallow therapy as it relates to our
Mhm.
patients with dementia. So this is like something that like if I could just shout it from the mountaintops that I would
This is
do.
it.
So, the outpatient facility that I work at, we have an expert in Parkinson's care. So we get a lot
Mhm.
of Parkinson's patients, and as you know, a lot of our Parkinson's patients also have dementia.
Mhm.
So we have implemented proactive therapy for both our patients with Parkinson's as well as our patients with non-Parkinson's dementia. And we have an LSVT program. And pretty much automatically, if we get a patient that comes in with dementia, regardless of what they're coming for us, to us for, we refer them for a modified barium swallow study. And
Mm.
the reason being is that especially when you think about those, when you look at the article, you see that you have more severe impairment as the dementia progresses. So when we start getting into that
Mm.
middle to late stage of dementia, you know, things like the spaced retrieval intervention to help recall swallowing techniques might not work anymore.
Mhm.
Um, so what we do is we get these patients in early and we could start seeing like that there's a very, you know, this patient might not even be experiencing dysphagia, but when you do that
Mhm.
instrumental, you see that like they're right there on the fine line between presbyphagia and moving into a disorder. So you might
Yep.
see like pretty significant molecular residue, pretty deep penetration that's starting to not clear, and we prescribe prophylactic swallowing exercises. So, the
Mm.
reason why we do this is we get these patients started with these exercises, and then you have greater physiological reserve as the dementia progresses. So, and we also can train strategies and get these strategies into the patient's procedural memory. So that's that memory that we use that they say, like, once you learn how to ride a bike, you never forget.
Yep.
So we get those strategies started earlier so that they're automatic with the hopes that that lasts as the dementia continues to progress. So my greatest recommendation is that if you have that privilege to get those patients started early on these exercises,
Mhm.
and then conversely, if you're a community therapist that does modified barium swallow studies, if you have a patient with dysphagia that comes in directly to you and has not actually been seen clinically in a clinical setting, please refer them for a follow up, even if they're, you know, not aspirating or you don't see anything on your modified, because those other factors that we talked about, like the cognition and the feeding, could be at play that are leading to the symptoms. And you're not going to see that in your modified. So,
Yep. Great. That's absolutely fantastic. I don't think that we think about that enough, especially with the dementia population, but also in general, just getting in there early to try to, maintain that function for as long as possible. And maybe it's because
mhm,
we don't have as much research for that.
mhm.
But I definitely think it's something that we should be doing more often.
Yes. Yes. And you see, I think just like what you mentioned earlier, that dementia just doesn't get enough attention.
Mm,
You know, if you're listening and you're thinking about doing a PhD, this would be a great area to do some research in, because we see prophylactic therapy helping with other populations. So, like with our head
mhm.
and neck cancer population, we start them on exercises before starting radiation. And then with our ALS populations, we're doing EMST to try to um, maintain breath support and cough strength for as long as they
Yep.
can. So I do think that it's, you know, I agree, it's under researched, and I think that would be a very helpful area to study more. So.
Yeah, absolutely. Well, my last question was actually going to be, what's one thing that you'd like to communicate to our fellow species? And I think that that's the thing, isn't it?
Yes, absolutely.
Great. All right. Well, that brings us to the end. Again, thank you so much, Jackie. I actually learned a lot from today and got some great tips that for sure I will be using.
Yay, thank you for having me.
And Jackie, if people want to get in touch with you on the socials, where can they find you?
Yeah, so on both Instagram and Facebook, I'm unlearn with me dot the SLP. And then I believe on LinkedIn, I'm Jacqueline Rodriguez. Jacqueline spelled JACQUELYNNE.
Thanks for tuning in to the Dysphagia Research